Hi, Joyce.
Hi, Maria.
Good evening, everybody. Welcome to another episode of Gynecologist, which is the Facebook live stream event produced by Women's Healthcare of Princeton. I'm really lucky tonight to have an exceptional physician and a friend and colleague, Dr. Joyce Varughese, who's the chairman of Gynecologic Oncology at Capitol Health Medical Center and is a member of the surgical group at Capitol Health. And she's here with me tonight. We're going to talk about GYN cancers, what they are, how common are they, and how can we prevent them, and which ones can we prevent, and which ones are difficult to diagnose, and what we can do. Dr. Varughese gave a lovely talk this morning to physicians, and I learned a lot about all this. And she agreed to talk with me tonight about what patients can learn and what they can do. So welcome. Thanks for taking your dinner time, Dr. Varughese.
Thanks for having me, Maria. It's my pleasure. Appreciate being here.
So first question, if I were a patient and I just want to know some basic stuff, is what exactly is a gynecologic cancer? What are the types of GYN cancer?
Sure. So there are 5 main types of gynecologic cancers. Uterine cancer, of which the most common type is endometrial. So you sometimes hear those terms used interchangeably. Cervical cancer, ovarian cancer, vaginal cancer, and vulvar cancer are really the most common types that we see. There are some more rare tumors, but for all intents and purposes, those are the ones that we talk about mostly.
Okay. And which ones might when I go to a gynecologist for an annual checkup, what is the gynecologist doing to check for each of those cancers?
Sure. So the only one that we really
All of them. That's what my patients always say. Well, I have the PAP, so that's everything, right?
Right. So of those, actually, the only ones that we actually have a screening test for is really cervical cancer. And that's the pap smear and HPV testing. But importantly, and HPV is human papillomavirus, and that's the virus that causes the vast majority of cervical cancers. But the reason why going to the gynecologist every year is important, even if you're not due for a pap smear, is because they're also looking at the vulva, which is the outside portion of the GYN organs, and looking in the vagina. And the vagina and the vulva can also be affected by HPV. The other things that the gynecologists are doing an exam to feel for any pelvic masses, to see if there's any areas of bleeding or any other abnormalities. So even if a patient doesn't need a pap smear for 1 year, it's still really important to go to the gynecologist. I think people equate going to the gynecologist with a pap smear, and now with pap smear screening no longer really being annually, it's really important that you still visit your gynecologist because they're looking at much more than just cervical cancer screening.
And I get asked that all the time. Why aren't pap smears every year anymore? What's changed about the test, or are insurance companies trying to shortchange us, or should we really have a pap every year? And why isn't that every year anymore?
Right. So that's a great question. So years ago, all we had were pap smears, which is really basically taking a small little sample of the cells on the cervix, and the pathologist the lab looks under the microscope and looks at those cells. But then we had this wonderful discovery that HPV, or human papillomavirus, causes the vast majority of cervical cancers. So now we actually test most patients. It's kind of nuanced about age and a lot of other things. We test patients with not just the pap smear, but also with HPV testing. So we know that patients who have a negative HPV test probably don't need a pap smear every year. And so that's what's changed. It's not that insurance companies are trying to shortchange you. It's more that the HPV test, we know, actually shows a lot more than, tells us a lot more about your risk of developing cervical cancer than the pap test alone.
Got it. So the test has changed. It's more robust, and it's sort of valid for 3 to 5 years now.
Right. And that's really only in patients, though, who've had regular pap smear screening. So this doesn't apply to a patient who hasn't gone to the gynecologist in 25 years. You're probably going to be getting a pap smear every year for a few years.
Right.
Or
Or if you've had abnormal, or if you've had an
right,
abnormal pap smear,
exactly.
right? So if your pap's been abnormal, your clinician might say you need to come back in a year for another pap test, an
Exactly.
HPV screening. But I think your point is well taken that the pap is not the visit. It's just one part of it. And so when we're doing a pelvic exam, we're feeling for masses in the pelvis and we're looking with our eyes at other things.
I mean, gynecologists, my gynecology colleagues have diagnosed skin cancers because if you think about it, the vulva is just another part of the skin. Um, the other um, thing that I'm sorry, the other things that gynecologists have diagnosed are rectal cancers doing exams. So yeah, there's a lot of other things that can be diagnosed.
Should your gynecologist be doing a rectal exam?
Um, that it depends on age and et cetera, but usually with an annual examination, a rectovaginal examination is fairly standard because you can get a lot of information about the back part of the uterus. You can actually miss some pelvic masses without doing a rectal exam. So I do those on all of my patients, and I do recommend it.
Yeah.
I know it's uncomfortable for the patient, but it really does give us a lot more information.
And I think the important point here is for women to know what's appropriate and to advocate for that. So, we've all been to the doctor when they've been in a hurry and they kind of say, well, I didn't do it this time. It's okay to advocate because you want to get a thorough exam. You're making an appointment, you're paying a copay maybe, and you should get examined. What about the other kinds of cancer? We talked, well, can we finish on cervical cancer and just, or stay on that?
Sure. So, in terms of preventing cervical cancer, so as I mentioned, the vast majority, over 95% of cervical cancers are caused by HPV, so they're potentially preventable. So, one is by getting your pap smear and HPV screenings, because the whole point of those tests are not to detect cancer, but to detect precancers of the cervix so that we can treat them and prevent them from progressing to cervical cancer. The other way that we have is we actually have a vaccine to prevent cancer. The HPV vaccine is protects against 9 different strains of HPV that we know cause not just cervical cancer, vulvar and vaginal cancers. It can cause head and neck cancers. There's actually more HPV-related head and neck cancers diagnosed in the U.S. than there are genitourinary cancers in men and women combined. It also can cause penile cancer, anal cancer. The HPV vaccine can protect against those different cancers. The HPV vaccine can also protect you against genital warts as well, because those are also caused by certain strains of HPV that are included in the vaccine. The vaccine is approved from ages 9 through 45. So most of the national organizations recommend that children get vaccinated around the age of 11, but can start as early as 9. In women and men who have not been vaccinated up to the age of 26, they recommend this catch-up vaccination. From 27 to 45, they say that you should really have shared clinical decision making with your physician. What that basically means is you should really have a discussion with your doctor about whether or not it's appropriate for you to get the vaccine. But it is approved up through the age of 45 in men and women.
Okay, so that gives me a bunch of questions. So you're
Sure.
just glad I'm not your patient because I'd be asking you a lot of things right
Mhm.
now. Well, one of them has to do with what do you mean? Like, how do you decide who's appropriate? In other words, if I'm dating again and I'm divorced and now I'm dating and I didn't get the vaccine as a kid because I'm not that young, my generation missed it. Should I get the vaccine? Do you think?
How old were you? Are you now?
29. No,
And how old are we in this pretend world?
in COVID, it feels like I'm
The
100.
pretend patient, how old?
This pretend patient is 42,
Okay.
and she didn't get vaccinated as a teen because we didn't have the vaccine then, and she's only been with her husband, who now she's divorced from, but she's now gonna online date and eventually hopes to have sex again.
Right. So that's something that she should, discuss with her doctor because she's has an increased risk of exposure because she's now out being exposed to other people who potentially have HPV. I should mention that over 80% of American adults have been infected with HPV at some time in their lives. So it's not anything,
Rare.
it's not rare. It's nothing to be embarrassed about. It's not, because that's the other thing that a lot of patients are concerned. And it's so common that it's why we encourage vaccination for all boys and girls, men and women, 9 through 45, whoever's eligible.
Right. And let's just pause for a second and realize how incredible that is, that a childhood vaccine has now been approved and paid for until the age of 45, which tells you honestly how important that is and how dramatic it is that in terms of the ability to save lives from cancer, that both the CDC and insurance companies feel that this should be a national almost mandate. And I think in the crazy statistic I'll throw out is that in Australia, they have almost 100% of their teens vaccinated, and they have declared, correct me if I'm wrong, that by 2025 or something, they will have eradicated cervical cancer. So that's like gives me goosebumps. That's a dream we could aim for.
What I always say is insurance companies look for ways not to pay for things. So the fact that they're willing to pay for the HPV vaccine, I mean, it's an incredible burden to them if somebody develops cervical cancer. Treatments are not, are much more expensive. They're surveillance. I mean, there's so much more, and not to, that's one piece of it. That's probably the least important part, but really the burden to, the patient, society, all of that. So, but it's pretty incredible that it is that it is covered and improved. So, but Australia really led the way for the world in terms of HPV vaccination. They had a really robust vaccination program from the beginning.
I know, and now look how great they're doing with COVID. I'm moving there. That's it. Also, really nice weather.
The other thing I want to mention is even though HPV that affects about 80% of American adults, cervical cancer itself is pretty rare. In the whole United States for this coming year, for 2021, it's estimated that we're only going to have diagnosed about 12 to 14,000 new cases of cervical cancer. So that's the entire United States population
for a year.
So it's really not incredibly common. When we talk about uterine cancer, we estimate there's going to be over 65,000 new cases of uterine cancer. So, the message I want people who are listening to this to take away is that it's really important that if you're in the age group that you could get vaccinated, to get the vaccine, and number two, to continue with appropriate screening for cervical cancer.
Got it. So let's go on to uterine cancer, but two quick questions. One is, I get asked all the time, same people out there dating, teens, middle-aged, geriatric patients, what about oral sex? Are they going to get HPV? And we don't have any way to screen for that, right? What can we do about head and neck cancers from HPV?
So the vaccine has been covers the types of HPV that we believe are related that cause HPV-related head and neck cancers. So really, right now, the only preventive mechanism you have is the vaccine. There's no officially approved screening test for HPV-related head and neck cancers.
I know. My brother's a dentist. I ask him every year.
Right.
Not yet.
Right. The other thing I just want to mention about preventing cervical cancer before we move on is that so again, 80% of American adults infected with HPV. I don't see 80% of American women, or women coming through my office with precancers or cancers. There are other modifiable risk factors, and the biggest one is smoking. Okay. So if you smoke, stop for a variety of reasons, but from a purely selfish standpoint, it increases your risk of the HPV sticking around and changing your cells and making them precancerous and then leading into cancer. So when young women come to me with abnormal pap smears, if they smoke, the first thing we talk about is how we can help them to stop smoking. I don't want to make it seem that it's so easy if I just say stop smoking to stop, because we know that it's an addiction. There's biological changes that happen. So seek help to quit smoking, but it's going to be the best thing for your overall health and also to prevent these cancers.
Right. Thank you. And your other point is so well taken. I want to repeat it, just that if over 80% of American adults have been exposed to it, and yet we only have 12 to 14,000 cases a year, most people are going to clear this virus on their own, not get rid of it. It's not that it's gone forever, but how does that happen? How is it that they don't ever get the pre-cancer? What does our body do?
Right. So just like any other virus, it's funny we're talking in this day and age, right? Everybody's a virologist. We all know about viruses. So just like any other virus, your immune system will, fight this virus. So when you got a cold virus in the past, your immune system fights it. So similarly, your immune system takes care of the virus, or either clears it or quiets it down kind of within the body. The thing about HPV that makes it hard is, as long as people are sexually active, they can, whether or not they're going to clear the virus is a little bit harder. Whether they clear it and then get reinfected, nobody really knows. But regardless, your immune system usually will help take care of it so that it doesn't make changes on the cervix.
Mm-hmm. Thanks. Okay, now we can go to the uterus. So uterine cancer, and let's just remember again the other word you said, endometrial cancer. The endometrium is the lining of the inside of the uterus, but that's really where most uterine cancers start, correct? So that's why we call uterine cancer also often endometrial cancer.
Right. So all endometrial cancers are uterine cancers, but there are some uterine cancers that are not. It's just that endometrial cancer is the most common type of uterine cancer.
Mm-hmm, mm-hmm. And that makes sense because it's the lining that's sort of active every month while we're in reproductive age. That's what grows, waiting for an egg and sperm. And then when that doesn't happen, it sheds. And that's what we call a period. But it's not really the periods that set us up for cancer. What kind of things are risk factors for uterine endometrial cancer?
So, unlike cervical cancer, where a vast majority are preventable, with endometrial cancers, we know about 40% are potentially preventable. And the reason for that is the biggest risk factor or the most common risk factor that we see in the United States today is obesity. And you might be like, well, how does that have anything to do with what's going on in the lining of my uterus? Well, I'll tell you, Dr. Sophocles kind of hinted at it. She was talking about hormones, kind of fluctuating during your reproductive years. But what occurs is that the lining of the uterus is sensitive to two hormones, estrogen and progesterone. And during your reproductive years, those hormones kind of change as the month goes on, and then you shed it as a period if you're not pregnant. In pregnancy, those hormones kind of the levels change in a different way. But after menopause, your estrogen levels drop, right? That's one of the almost definitions of menopause. The ovaries are what secrete estrogen for the most part, and those stop functioning as well, and so you have less estrogen on board, and that's fine. However, in women who are overweight or obese, we know that they have estrogen production in their fatty tissue. So the reason why that happens is testosterone, which men and women have, gets converted to estrogen in the fatty tissue. It's sort of like how I explain it to my patients is if you see really overweight or obese men, it looks like they have breasts. That's not just fatty tissue. That's their testosterone getting converted to estrogen, stimulating their breasts to grow. Mm-hmm. So obesity, so being obese increases a woman's risk of breast cancer because of that extra estrogen, and also increases our risk of uterine cancer because now the uterus is seeing a lot more estrogen and not enough progesterone to stabilize it. So that extra estrogen is really what causes this increased risk of endometrial cancer. So one of the ways to potentially prevent these cancers are to maintain a healthy weight and maintain a healthy lifestyle to reduce your risk.
And not just, and then, so when we talk about top risk factors, obesity by far, but also diabetes, high blood pressure, and smoking too, I think, for the uterus, or
not smoking.
So diabetes, high blood pressure, overweight,
mm-hmm.
Which actually, once people are very overweight, they often become diabetic and hypertensive anyway. We call this metabolic syndrome. Right. So if you have metabolic syndrome, you have to worry not just about the fact that you're diabetic and that your cholesterol's up and your blood pressure is up, but you have to be worried about the fact that you're now feeding your uterus estrogen without the balance of the protective nature of progesterone, right?
Exactly.
Okay. If that's not a good reason to lose weight, I don't know what is.
The other cancers that are potentially preventable within uterine cancer are there is a familial cancer syndrome, something called Lynch syndrome,
Right.
where women inherit a gene from either their mother or their father that increases their risk of certain cancers, including uterine, ovarian, and colon cancers. And so, the thing is that now families are smaller. A lot of people don't know their family histories. To be honest with you, GYN issues and GYN cancers are not discussed at the Thanksgiving dinner table, right? And so, all we know is that, Aunt Claire had a hysterectomy at the age of 50. We think it might have been cancer, but nobody really knows. And she lived another 30 years, right? So, but knowing your family history is really important because patients with Lynch syndrome actually have a significantly increased risk of developing uterine cancer and developing it at a younger age. And so in those patients, we either offer a hysterectomy once they're done with having children. And if they're not done having children, we actually do offer some screening tests. There are no screening tests for uterine cancer for the general population, though.
No, but you can know what might be a good symptom of it that
Right.
would get you on the phone to your gynecologist or into their office.
Right. So any abnormal vaginal bleeding, specifically, most women with uterine cancer are diagnosed after menopause. And so any bleeding after menopause, meaning you've gone more than a year without a period, and now you start bleeding, even if it's just a spot or two, even if it's just when wiping, even if it's like a brownish discharge, that needs to be evaluated. I can't tell you how many patients were like, but it was just a spot, and so when we say bleeding, we don't mean a full-on period. We don't mean large clots or any of that. It just needs to be evaluated. Chances are it's not cancer, but that needs to be ruled out. I see a lot of younger women now in who are not menopausal, so pre-menopause. I've diagnosed uterine cancer in women as young as 25. So really knowing what your regular cycles are like, and if you have irregular cycles, having that evaluated is beneficial. Because the good news about uterine cancer is because there's a symptom, because people bleed abnormally, most are diagnosed at stage 1.
Right.
So this is very curable, and most patients just need a hysterectomy. Very rarely do they need additional treatment. But again, you have to seek evaluation first and early to be able to cure it.
Excellent. Well said. We have a question, and I think it's a great question. Would it help to reduce the risk of uterine cancer to have progesterone supplementation? Because we talked about how if estrogen's the fertilizer and progesterone's the weed killer, or whatever you want to say, if one is stimulating that growth and the other is prohibiting, why don't we just give progesterone to everyone after menopause?
Right. So one of the lovely side effects of progesterone when you take it systemically is an increased appetite. So, here we are trying to maintain a healthy weight, lose weight if you're overweight or obese, this sort of thing. So, all supplements or medications are, come with their own side effects. So, using progesterone may counteract some of the other information we're giving you in terms of healthy lifestyle. So we don't recommend progesterone supplementation for all women post-menopause because most women will not develop endometrial cancer, right? And
right. Better to just not be overweight and know your family history. And if you have a family history, not just of uterine cancer, but of colon cancer. If you have 3 uncles who had colon cancer, you should let your doctor know that, and hopefully your doctor will say, okay, how about any uterine cancer, and test you for Lynch. I think that's really important to know your family history.
I've had a few patients where their because, like I said, families are small. We don't really know. And I distinctly remember one patient who I didn't think it was a soft call to send her for genetic counseling, but she came back and told me, oh, genetic counselors weren't quite sure why you sent me to see them, but they tested and she was positive for Lynch syndrome. So, we potentially prevented colon cancers in her because she's now getting increased screening for that. as we learn more about the different genes that cause these different, familial cancer syndromes, it's I think I strongly believe knowledge is power, right? So
Right,
it's
right,
a matter of getting to the right people to get that knowledge. So
right,
Karen has a great question of how do you test for Lynch? So it's a blood test that you look at for specific genetic mutations.
right, right. And again, if you have Lynch, it's better to know. I have patients say, "I'd rather not know." It's better to know so that you can be appropriately watched and it
Right.
can be paid for.
Right.
Also, back to the progesterone question, there's progesterone and there's progesterone. There's systemic oral progesterone and there's progesterone with an IUD. And I'm not saying everyone should run out and get a progesterone IUD, but we talked about this morning a little bit that if you, for example, if you're taking estrogen as hormone replacement therapy and you have a uterus, you need progesterone. And there's taking it systemically, which is generally safe, but can, we think, have side effects and possible risk. Whereas having progesterone via an IUD is more of a local effect. So it's even a way to reverse the abnormal cells in the uterus if they have hyperplasia. Can you talk a little bit about that, what that is? And
Hyperplasia.
mhm,
Yeah, so endometrial hyperplasia is precancerous cells of the uterus, and that again develops in response to extra estrogen on board. And so those are usually treated, depending on the type of hyperplasia, can either be treated with progesterones to again restore that balance that we were talking about between estrogen and progesterone, or actually with a hysterectomy, because there's a specific type of hyperplasia called atypical hyperplasia, where we know that women who have that diagnosis, actually 40% of them will actually have a uterine cancer somewhere in the uterus,
mm.
because that hyperplasia has already progressed to cancer. So in those patients, we recommend a hysterectomy.
So I have a patient with complex atypical hyperplasia, and she really doesn't want to have a biopsy, or she really, a hysterectomy. Really, really doesn't. She's very afraid of surgery. So she explained that she'd like to try to do this holistically and just change her diet and try to get good sleep and mindfulness and see if maybe the cells will just revert. What um what would you tell a patient like that?
So I think so once it's already progressed to hyperplasia, you have to treat that. I'm a big believer in food as medicine, sleep as medicine. But once you've gotten your cells have already changed to that point, the likelihood of them just reverting back and spontaneously regressing is pretty low.
Right.
Making all those changes could help prevent progression of that and worsening of the disease. So more cells becoming hyperplastic or the hyperplasia progressing to cancer. But what I would tell her is treat it with progesterone, like put an IUD in or use systemic progesterone, make all those lifestyle changes, see if you're able to reverse it that way, with the progesterone, and
Yeah.
then, continue with your lifestyle changes as well.
Yep, yep. She knows all that and she's thinking about it, but she's also very afraid of the discomfort from an IUD, which I think the insertion, I think this just begs the question of with these decisions, everyone has to weigh, cancer IUD insertion may be uncomfortable for a little bit, but cancer can be really uncomfortable and a lot more cost to your quality of life. So we have a good question. Do you want to take a look at that one?
Sure. So Desiree asked, I had ovarian cancer. Should my daughter be tested for Lynch syndrome? So really, the person that should be tested, have a genetic test is you, the person who had the cancer, and you should have what we call a multi-gene panel. And if that's negative, then and I don't know what your daughter's father's family history is like, but if you're negative, well, then she wouldn't have inherited a gene from you. So then you have to look at her father's family history and whether it's appropriate to get her tested.
And just a quick coverage point, Desiree, that if you have ovarian cancer, and especially if you have any other family members with cancer, it's likely that that genetic testing will be covered. Genetic
Mhm.
testing used to be extremely expensive, and it's one of the parts of medicine that amazingly is now almost always covered if you qualify.
Right.
So don't be afraid that it could be expensive. Embrace it because you could be buying valuable information for your daughter.
And I always recommend seeing a genetic counselor because they really understand the nuances of this of the insurance industry as well in terms of covering things. But also, they'll be upfront with you and tell you what if any out of pocket costs you would have before ordering any testing. So, the counseling is one piece of it. The testing is the second part of it. So it's not like you're going to go and like all of a sudden you're going to get hit with the $1,000 bill because they tested you for something. They're going to, let you know what is, what would be appropriate and what would be covered and any out of pocket costs.
Right. So I know there's more questions coming. So let's try to get through our ovarian cancer. So at least we can hit the big three. And yeah.
So in terms of ovarian cancers, this is one of the more rare cancers in the United States. Only about 12,000 will be diagnosed in this coming year, 2021. And so, unfortunately, like I said, with uterine cancer, we don't have any screening tests. With ovarian cancer, we also don't have any screening tests. And really, as far as we know so far, really only about 5 to 10% of ovarian cancers are potentially preventable. We lump ovarian and fallopian tube cancers kind of together for a wide variety of reasons that we don't need to get into here today. But just know that, when I'm saying ovarian, I'm really including ovarian and fallopian tube cancers. And really, the reason why such few of them are the ones that are preventable are really ones in patients who carry a gene that increases their risk of developing an ovarian or fallopian tube cancer. So the most common ones that people know are BRCA1 and BRCA2, or BRCA1 and BRCA2. And so it's really important, just like I mentioned with Lynch syndrome, that you know your family history. The cancers that are most commonly associated with BRCA1 and BRCA2 mutations are breast cancers, ovarian cancers, pancreatic and prostate cancers, especially in younger age, at a younger age, male breast cancers. So if you know that you had an uncle who had a breast cancer but don't know any other details, it's probably worth getting tested because that's just really a red flag that it might be because of a genetic mutation.
Right. So how are most ovarian cancers diagnosed? By patients or by their doctors?
So unlike uterine cancer, where I
If you
said that,
see them after they're already diagnosed usually.
yeah, right. So unlike uterine cancer, where I said the vast majority are diagnosed stage 1, unfortunately, with ovarian cancers, most are diagnosed stage 3. And the reason for that is because the symptoms are really vague. And most patients have like anywhere from a 6 to 18-month delay in diagnosis because they're worked up by their primary care doctor who sends them to a GI or gastro doctor because they're having really vague abdominal symptoms. And many women will talk with their friends, and their friends are like, oh, yeah, that happened to me after menopause. I started getting a little belly pouch or, changes in your bowel habits and those sort of things. So what I say, and we don't have a screening test. And ovarian cancers at stage 1 and 2 are, there's no real, they don't really have symptoms, right? So what we say is that if somebody presents, or if you're having symptoms that, with changes in your bowel or your bladder habits that persist for more than a week, or more than 2 weeks is really what we say, that it's, your body best, right? And so it's something that's worth getting evaluated. Is it likely to be ovarian cancer? Probably not, because it's a really rare cancer. And so is the other workup appropriate? Absolutely. But if those aren't really explaining the symptoms, then to keep that in mind, and of course to see your gynecologist.
And at that visit, you do want to make sure your gynecologist is going to do a rectovaginal exam because it's easy to miss ovarian masses just doing a quick pelvic exam without a rectal exam as well. I've missed things myself where I wouldn't have gotten it unless I had done a full exam like that. One of the most common questions we get asked is about the CA-125 blood test, which sort of became popularized, I think, after Gilda Radner died of ovarian cancer, and her husband, I mean, with all the best intentions, I think, had a national campaign just urging women to demand that they get this blood test to find the ovarian cancer. You and I know that's not accurate. Can you explain to patients why it's not a screening test?
Right.
And why don't we just do that on everybody?
So first, we should even just step back. What do we mean by a screening test, right? Screening tests that we know of, right? Mammograms, colonoscopies, Pap smears. What do
Yep.
they have in common? Our goal is to diagnose precancers. That's what a screening test does. It's to diagnose precancers or very early stage cancers that can be cured, and the precancers that can be treated to prevent them from becoming cancer. So that's what the goal of a screening test is.
Right.
So we do, when I say we don't have a screening test for ovarian cancer, and people bring up the CA 125, the CA 125, for those who don't know, it's cancer antigen 125. It's a blood test that looks at the specific tumor marker. It is a very useful test if somebody that you know has ovarian cancer, and you check it, either right before surgery or at the time of surgery, and it's elevated, then you can follow it once as they're getting treated as a marker of response to treatment.
Right.
Great, really good for that. But I have plenty of patients with stage three ovarian cancer who have a totally normal CA 125 when they're diagnosed. So it's not a specific test, and it's not a sensitive test, meaning that it doesn't rule anything in and it doesn't really rule anything out. CA 125 is really a marker of inflammation inside the belly. And so there are many things that will increase your CA 125. If you put a group of reproductive age women in a room and checked all of their CA 125s, you could tell who is menstruating, because theirs are probably going to be a little bit more elevated than their friends or colleagues who are not. If you have endometriosis, which is a totally benign condition, if you have large fibroids, totally benign condition, your CA 125 can be elevated. If you have a benign ovarian mass, because let's face it, women, the ovaries make cysts every month when you're in your reproductive years, and there's a lot of ovarian masses that are benign. The vast majority are benign, even in postmenopausal women. Your CA 125 will likely be elevated because there's been irritation.
So if we order CA 125 on all these people, and suddenly we have all these false elevated CA 125, we'll be doing surgery for people that don't really need it.
But not just that. So I only talked about the GYN causes of CA 125 going up. If you have an appendicitis, your CA 125 will likely be elevated. If you have a gastroenteritis, a stomach bug, a stomach virus, it will likely be elevated. Diverticulitis, it will likely be a little elevated. Anything, if you have liver disease, cirrhosis, that causes ascites and fluid in the belly, causes inflammation, the CA 125 will undoubtedly be elevated. So again, it doesn't really help us in terms of screening for ovarian cancer.
Right.
The only times we use it, we potentially use it for screening, is in patients with BRCA mutations who we know are at increased risk for ovarian cancers.
Should those patients have a CA 125 once a year?
So it depends on their age, on a lot of different things. If they've had risk-reducing surgery, then no. If they haven't, then we offer it every 6 to 12 months. But again, it's
two.
I'm sorry.
BRCA1 and BRCA2.
Yes. Mm-hmm. Yeah.
Okay. In case any of you out there are BRCA1 or BRCA2 and you're not.
Right. Well, and we don't offer it and we don't do it in isolation. What we recommend is that they also get an ultrasound. So that's the other question we get is, well, why doesn't everybody just get an ultrasound for ovarian cancer screening? Because like I mentioned, there's a lot of masses that we'll find that are going to be completely benign, and we'll be putting people at the risk of surgery and anesthesia for really very no benefit, to be honest with you.
Mm-hmm. Mm-hmm. Some countries have instituted this, an annual ultrasound for every woman, and some of them even have toyed with annual CA 125, and it's never proven to really reduce the ovarian cancer death rate, correct? Yeah. So great question. I wish we had a screening test. I wish it was CA 125, but it's not, and it's important to understand why it's not a good screening test for ovarian cancer, actually why it's not a good screening test for any cancer, CA 125, but we do use it to follow like chemotherapy regimens and see that there's been improvement.
Right.
Okay. Vulvar cancer, most people don't even know the vulva can get cancer.
So the vulva, as I discuss it, is that it's just skin like any other part of the body. So any skin cancer you can get in any other part of the body, you can get on the vulva. Squamous cell cancers, basal cell cancers. Believe it or not, melanomas. I know everybody associates melanoma with with sun exposure, but vulvar melanoma is uncommon, but it exists. It absolutely can be diagnosed. So again, a really important reason why you should see your gynecologist once a year to examine the skin in that area. So, vulvar cancers can be HPV related, but some are related actually to other skin conditions like that, cause itching and dryness in the area. So again, it's just important that you know your body and that you examine that area, but also that you see somebody who's going to be checking it at least annually.
Right. And if you have constant itching or burning of the vulva, even if your primary care or your gynecologist keeps telling you it's just yeast, I would be very leery of that. And I wouldn't necessarily accept it because I see many patients who've been treated for yeast for years and they have a chronic vulvar condition, but it's not yeast. It's something called lichen sclerosis. Sounds a terrible name, but it's a skin condition a little bit similar to eczema, but it does have a link to vulvar cancer, correct, Joyce?
Yeah, absolutely.
So
Chronic irritation really, can cause changes in the skin and in the cells that can lead to cancers.
right. So don't just accept that it must just be yeast, especially if you're not getting better with yeast treatment because it could be something else. We have some other people who had some questions. Maybe we can see those questions and then answer some of them because I know we're going over, but it's kind of such a good topic, and I think people want to know.
So Kay Benjamin asked, many Black women have fibroids. Is that a sign that there might be a gynecologic cancer in her future? No, not necessarily, because fibroids, which are benign uterine tumors, just basically they're benign growths of the muscle of the uterus, are very common. And you're right, they are much more common in African American women. It is very rare for cancers to arise within fibroids or for fibroids kind of um, develop into cancers. But that being said, African American women are at increased risk for some of the higher grade uterine cancers, meaning the more aggressive uterine cancer, completely unrelated to fibroids. So it's really important that all women, but particularly African American women, if you have any postmenopausal bleeding, abnormal bleeding, that you seek care right away.
Mhm.
That's a great question. But fibroids are fortunately very common and very benign.
Okay. Gail Titus. I'll read this one to you. You can take a sip of your
I
tea.
would take a sip, yeah.
I had a benign finding following a hysteroscopy that was done due to abnormal postmenopausal bleeding at age 60. I was advised to have a hysterectomy, removal of the uterus, tubes, and ovaries. I have great aunts who had gynecological cancer and colon cancer. Should I pursue a test for Lynch syndrome? I think that's a fair question.
Um, just from the limited information we have, I think it is certainly something you should talk with your physician about. About a referral to a genetic counselor because they would be able to get a much more extensive family and personal history
Right.
and recommend the test that may be appropriate. But certainly with the multiple uh, family members, I'm assuming on the same side of the family who've had cancers that fall into the Lynch syndrome kind of family of cancers, I guess, that it is something certainly worth asking about.
I think so. And remember, a genetic counselor will spend an hour going through all your relatives and sort of adding and ranking who had which cancer and whether, with all that together, you really qualify or merit genetic testing. Because some people will say, well, my second cousin twice removed had pancreatic cancer, but no one else has had anything. And it's hard. And I'll speak for myself. I'm not a qualified genetic counselor, and most physicians don't take a full enough picture to really be able to say, unless it's super obvious. But Gail, I would think for you, getting to a genetic counselor, which is pretty simple. I mean, most university centers and even most community hospitals now have a genetic counselor. Capital does, correct,
Yep,
Joyce?
Capital Health, we have several genetic counselors. Yep.
Okay. You want to do Tiffany?
Oh, sure. So it says, my mother died of ovarian cancer. I'm sorry to hear that. Um, and I would like to get genetic testing. Can you recommend genetic counselors? So Tiffany, without knowing really where you are located, it's hard to say. But I'm at Capital Health, which is down in Pennington, New Jersey, and we have genetic counselors there. But as Dr. Sophocles mentioned, if you ask your primary care or your gynecologist, they, I'm sure, can refer you to a genetic counselor, because, as Dr. Sophocles said, most um, hospitals now have a genetic counselor or have an affiliation with one, just because it is such an important part of some of these care nowadays.
Yeah,
Yeah.
CINJ, Cancer Institute of New Jersey, which is part of Robert Wood Johnson, has a large department of genetic
Like,
counseling.
I used to be at St. Peter's. They have a wonderful genetic counseling department there. But, if you pick any of the large, this is the thing about Facebook Live, is that you have no idea where people are. So if you're in New Jersey, all of the large health systems have genetic counselors on staff.
Yeah, and Tiffany, this Women's Healthcare's website is princetongyn.com, and you can go on our website. You can find a link to contact us, and I'd be happy to send you genetic counselors in the area that I know or that we work with, or we could even look up kind of a national link for you, depending on where you are, because we get patients from all over the country. So I'm often going on Google to try to find local genetic counselors, and it's not like a brain surgeon where there's a top guy in the world or something. I think most genetic counselors are really well trained in how to take a good history and advise you and guide you. So I think that's good. Joyce, did we get off topic? Are there any other cancers that we didn't hit that we should talk about?
I think in terms of preventable ones, I think we hit all of the GYN preventable ones, really.
I have one point I think would be cool to make. A lot of women, when they get their tubes tied, now we don't tie the tubes, we remove the tubes. And one of the reasons we remove the tubes is to reduce the risk of cancer. So, can you explain to everyone why we remove the tubes and why does that reduce our risk of GYN cancer?
Sure. So, as I mentioned a little bit earlier, there was a banner that went up that said ovarian/fallopian tube cancers. And I said I was kind of lumping them together for a little bit of nuance there. But so, not to explain this succinctly, Maria. So what we now know is that most of what we used to call ovarian cancers actually started in the fallopian tubes. The reason why we know this is because when we do risk reducing surgery in patients who have BRCA1 or BRCA2 mutations, because those are the ones we knew most commonly previously, we would remove their tubes and ovaries, and in the hopes of preventing future cancers. But sometimes we would be surprised and there would be microscopic cancers that we would find in these BRCA1 and BRCA2 patients. And what was surprising was not just finding the cancer or the kind of precancerous cells there, but where we were finding them were in the fallopian tubes and not in the ovaries. And so a lot of research has been done, and we now know that most of these cancers begin in the fallopian tube. Not all, but most. And so we now know that if you are doing surgery for a benign condition, so say somebody's having a hysterectomy because they have fibroids, we recommend removing the fallopian tubes at the same time to decrease their risk of fallopian tube cancer/ovarian cancer, because if the fallopian tubes aren't there, those abnormal cells aren't going to develop to then latch onto the ovary and develop into cancer.
So, bottom line, the fallopian tubes are not necessarily little benign standby arms out of the uterus. They have their own potential to host and harbor cancer. And so, if you're considering uh, permanent contraception, know that you're not only getting permanent contraception, but you are reducing your risk of cancer as well. And that kind of, go
Okay.
ahead.
No, the other thing I want to just mention is in terms of reducing your risk of ovarian cancer, which we didn't even talk about, and other than the in patients with
Right.
hereditary mutations. I know I mentioned BRCA1 and BRCA2. There are actually about 5 to 10 others that we now know also increase your risk of ovarian cancer. They're just not as common. But the other thing that has been shown to reduce your risk of ovarian cancer is oral contraceptive pills. So birth control pills, using birth control pills also decreases your risk of ovarian cancer.
That's dramatic. And do you have a kind of percentage ballpark? like I've read different statistics, but
Yeah, it depends on the study that you look at. We say,
I've seen 30, I've seen 40,
yeah,
but these are big numbers. And so I have so many moms who don't want to put their daughters on the pill because they said, I think it might cause cancer in her. And I think it's really important to understand that, at least from an ovarian cancer standpoint, it's not causing, it's reducing pretty dramatically. And I think it's because it's pausing ovulation. And we look at ovulation as each ovulation event is like a little mini injury, and then the ovary has to repair itself, right?
yep, that's exactly it.
So, so that's pretty cool that there is a way to reduce your risk of this terrible, terrible cancer that we have no screening for, and it's kind of right under our noses, really, and it's cheap and it's popular, and it can keep you from being pregnant too if you eat it, or regulate
Right,
your
regular
period.
periods too,
Right, right.
and keep your face a little clearer. Like there's a lot of
Ooh, oh my gosh, I know. We we, we're always looking for these other good benefits,
right.
so, um, I know there's a medication we use for sexual desire, and one of the side effects is you really kinda lose your appetite, so our patients are calling saying, "Guess what? I'm also losing weight." Great, great. Joyce, any other tips or thoughts about GYN cancers that really, I have one quick question. So if you're having your ovaries and tubes removed to reduce your risk because you have a family history, let's say, or one of these mutations, should you think about removing the uterus too? Because why not? You're there, and then you don't have periods, and aren't you then doing something that could become cancerous?
But it also increases your risk of surgery. It increases your recovery time. There's a lot of other things to consider. Depending on what your surgical history is, it may significantly increase your risk of surgery.
Yeah,
But in patients who have Lynch syndrome, we absolutely recommend removing the uterus. And
yeah,
in patients with a BRCA1, BRCA1 mutation,
right,
there's some data suggesting that those patients are at increased risk of a specific type of uterine cancer. So
right.
it is a discussion to be had with your physician about, and I do offer it to my BRCA1 mutation patients as well, to offer a hysterectomy at that time.
Okay, thank you. It's a small point, but I think it comes up when patients have that surgery. You know,
Mhm.
they say, why not just get it? And I do that same thing. Well, there's more surgery, more recovery,
Right.
but certainly in some women it makes more sense. So,
Right.
especially if
Exactly.
they have other risk factors for uterine cancer,
Right.
independent. So, all right, everybody. Well, I think we've exhausted Dr. Verghese, um, but she would love to help anybody who needs it. If you have other questions or comments, she's at Capitol Health. You can find her at Capitol Health, I'm sure, even though she's already super busy and super popular. I'm sure she'd love to help any of you. And I'm Dr. Maria Sophocles. I'm at Women's Healthcare Princeton, and I really thank you all for taking the time tonight to take care of yourselves and learn a little bit more about the cancers that affect us as women. Thank you, Dr. Verghese.
Right.
So
Thank you, everyone. We're putting some links also up. So if you want to, for some additional resources, you'll have those. Have a
great.
wonderful evening.
Fantastic. All right. Have a good evening. Good night. Thanks. Bye bye.